My name is Veronica Strang. I'm the IAS's Executive Director. I'm also a Professor of Anthropology. I work on environmental issues, water, people's relationships with places, and of course, water and dreams is another lovely topic. Bachelor, of course. So what I want to do really is welcome you to the very first of our virtual lecture series, and to say how very sorry I am that we're not all in the same room, but we hope that in due course that will be possible. The IAS Fellows Lectures are a vital part of our activities in showcasing what we do and what they do and the projects that we support. So even doing this virtually is such a valuable thing, and in many ways I think we're almost enormously lucky. So let me tell you a little bit about our speaker, Armando D'Agostino. He obtained his medical degree from the University degli Studi di Milano in 2007, and he then continued training in the same institution and registered as a specialist in psychiatry in 2012. And then he obtained a PhD in physiology, so already a wonderful interdisciplinary start there. He then became a clinical research fellow in the same university's Department of Health Sciences, and he teaches clinical psychiatry and neuroscience of mental disorders to undergraduate students and residents. And he's at this point supervised over 30 trainees and dissertations. And his research is very closely connected to his clinical work at Sao Paulo University Hospital's Department of Mental Health and Addiction in Milan. And his main research interests are the biological underpinnings of psychosis and mood disorders, their relationship with sleep, neurophysiology. He's published a lot on related topics, including sleep oscillatory activity in schizophrenia, chronotherapeutic approaches for depression, and of course the relationship between psychosis and dreaming, which is kind of where we're heading today with his lecture, which is very central to his involvement in the very wonderful Threshold Worlds project. So I will hand over to you, Armando, and welcome. Thank you.
Thank you very much, Veronica. It's a pleasure to be here. The topic is fascinating. The Threshold Worlds project is certainly of great interest to me, so I accepted this kind invitation to take part in the group. You said a lot about my past, so there's nothing much I can add. It's all there. I'm a psychiatrist. I've been so for 10 years at this point, and I still enjoy my clinical work with patients, and I attempt to bridge what I study in my research with what I see in my clinical activity. And I think this is the greatest joy for a clinical researcher, and possibly the greatest spring for me to continue in this type of activity. So I think we can move on to the lecture, and of course I'll be happy to answer any question that pops up during this lecture. And to stay afterwards for a hopefully interesting discussion.
Good evening. First of all, I'd like to thank the organizers of this public lecture at Durham University's Institute of Advanced Studies, and Drs. Alderson Day and Bernini, who are the PIs that introduced me to this fascinating Threshold World project. I'm going to try and talk you through the experimental observations on analogies and differences between dreams and psychosis. We will have a look at the history of this concept, which is deeply rooted in modern psychopathology, and then move to the contemporary debate on the topic, which is based on findings from the neurobiology of psychosis and on the framework of dreaming as a model for psychotic experiences. Then we will see the evidence emerging from some of the literature on the phenomenology and neurobiology of dreams, and from lucid dreaming, a state that we will see is highly related to the concept of insight in psychosis. Finally, I will show some of the advanced evidence on the relationship between sleep pathology and schizophrenia. So where do we start from? We can start from John Hewlins Jackson's famous quote, "Find out about dreams and you will find out about insanity." At the end of the 19th century, this eminent neurologist proposed that understanding the brain basis of dreaming should advance our knowledge on the brain basis of what he called insanity. Today, we would refer to this insanity as a detachment from reality that we call psychosis. Carl Gustav Jung, a few years later, working at Burgholzli with Eugen Bleuler, studied the language and thinking of patients with a disorder that was termed dementia praecox at the time. This was a term developed by Emil Kraepelin to describe a group of patients that we would now call schizophrenia. At the time, Emil Kraepelin was convinced that the cognitive decline was central to this disorder. And this is why he used the same term that Alois Alzheimer was using to describe a disorder that was occurring in patients who are elderly. Now, Carl Jung studied narrative aspects and language aspects of these patients and concluded that if we could imagine a dreamer walking around and acting his own dream as if he were awake, we would see the clinical picture of dementia praecox. Kraepelin himself kept a dream diary. This is less well known. He was very interested in his own dreams. And one of the most fascinating aspects of his diary is his work on the relationship between dream speech and schizophrenic speech disorder. Kraepelin was convinced that the ability to construct a logical phrase and to construct logically meaningful terms was related to the functioning of specific brain regions that should be shut down during dreaming. He was persuaded that the only way in which we could produce the atypical utterances of dream experiences was a hypofunction of the regions that are used to create speech during the wakefulness. Looking at patients with schizophrenia who had severe thought disturbances and severe speech disturbances, which were different from the aphasias that were studied in neurology, he observed some similarities. Things that we now refer to such as word salads or production of neologisms by patients were very similar to what he was recording in his own dream speech. Eugen Minkowski is very well known as a phenomenological thinker. And he quoted that dreaming man sleeps, and it is the sleeping condition which allows the desires to reveal themselves as bizarre and incomprehensible dreams by temporarily stopping the connections with the real world. Patient suffering from schizophrenia doesn't sleep, but sometimes his inner life shows the same characteristics. So Minkowski introduced two very important concepts. One is that the similarity between dreaming and psychosis is the loss of connection with the external environment. Dreaming is the product of an isolated brain, as psychosis is a product of patients' spontaneous brain activity, which continuously interprets the external environment, but cannot receive adequate feedback from it to correct its own views. The other important aspect is, of course, that dreaming is nested in the context of sleep. And this is a physiological way of understanding why the brain is detached from the external environment. In the case of schizophrenia, psychosis occurs in clear consciousness and in full wakefulness. This is an important distinction between these two states that might explain some of the relevant differences. But what is the contemporary debate? Polysomnography based on brain scalp electroencephalography completely changed the way we look at sleep. In 1953, Azarinsky and Kleitman identified rapid eye movement sleep, which was termed paradoxical sleep by another important researcher, Michel Jouvet. And this led the way to the identification of different sleep stages. We now know that through the night, we cycle from wakefulness to non-REM sleep to REM sleep and back again. In the early days of sleep laboratory research, back in the 1970s, most researchers were convinced that REM sleep must be the brain activity underlying dreams. As research developed over the years, we have come to understand that we dream across all stages of sleep. It does seem, however, true that fast frequency EEG signals that are typically seen during wakefulness and REM sleep must be present during other stages of sleep for the individual to gain consciousness. Of course, dream consciousness is something that occurs without contact with the external world. As you see described here, we have a transition from waking to REM sleep in terms of sensation and perception, which becomes dull or absent during non-REM sleep, and vivid and internally generated during REM sleep. A progression of thought, which moves from logical and progressive in wakefulness to logical and perseverative during non-REM sleep, to non-logical and highly bizarre during REM sleep. Movement is continuous and voluntary during wakefulness, becomes episodic and involuntary during non-REM sleep, and is commanded but inhibited during REM sleep. Alan Hobson, an American neurophysiologist from Harvard University, is well known for his activation input modulation model. So according to this model, sleep stages define different brain-mind stages, and each mental state is sustained by a different neurotransmitter modulation, a different intensity of activation in distributed brain areas, and a differential input from internal input to a predominantly external input. This was developed on the basis of the same researchers' activation synthesis hypothesis in 1977, which began to define dreaming as a form of byproduct of an activated arousal system from the brainstem that instigated the activity of different brain regions from those that are active during full wakefulness, possibly implying the intense bizarreness of the experience. This was seen as opposed to the dominant psychoanalytical view, according to which dreams are highly meaningful experiences which emerge from very profound This was seen as opposed to the dominant psychoanalytical view, according to which dream experiences are determined by very profound motives that instigate the enactment of a sort of dream theater. Mark Solms opposed Hobson's view by describing patients in which dreaming could occur in the absence of a preserved sleep physiology, and vice versa, patients with fully preserved REM sleep who had difficulty in retrieving their dreams. So the psychodynamic view is seen as a top-down propagation of signals in dreaming, according to which dreams originated from psychic motives that are later instantiated as sensory percepts. Whereas the activation input modulation model sees dreams as a bottom-up propagation originating from activation of sensory cortices by the brainstem, later to be interpreted and synthesized by mnemonic and high-order modules. What about the neurobiology of psychosis? Well, despite several decades of brain imaging, neuropathological, electrophysiological, and pharmacological studies, neurobiology of schizophrenia remains to be fully established. Reductions in gray matter thickness and volume, along with abnormalities of white matter integrity, have been consistently reported in patients. And when compared to healthy individuals, patients with schizophrenia and patients with risk syndromes have hypo or hyperconnected resting state thalamocortical networks. So we have a lot of evidence on the presence of brain dysfunction in these patients, but it's very difficult to identify clear relationships between the mental activity produced by patients and the underlying dysfunction. We know that schizophrenia is a condition which is characterized by a hypofunctioning frontal part of the brain and a relative hyperactivity of striatal dopaminergic transmission. So, how can we frame the concept of dreaming as a model for this condition? According to Alan Hobson, dreaming is a perfect model for what we call organic psychosis. Organic psychosis is the presence of hallucinations, illogical thinking, and abnormal behavior, which is associated with medical and organic conditions affecting the brain. Typically, alcohol withdrawal syndromes can precipitate to delirium, but also several other metabolic and organic conditions that occur, for example, in the elderly. So a patient with an organic psychosis, such as a delirium, is a patient who confabulates, constructs imaginary stories, hallucinates vividly and often visually, and has very abnormal behavior. If you observe a patient with a delirium, he could remind you of someone enacting his own dream. Our point, experimentally, was to address the view that dreaming could serve as a model for those psychoses that we see in psychiatric conditions. The difference with organic psychosis is that psychotic patients in psychiatric syndromes tend to be oriented. They tend to have a contact with the external environment, which is not dominated by confusion and lack of orientation. However, they do have abnormal behavior, which is often grossly disorganized, vivid hallucinations, which are more often auditory than visual, and they do have the firm belief that their internal experience is validated in the external environment, which is the type of thinking that also occurs during dreaming. During a dream, we are all convinced that we are experiencing everyday wakefulness. It is only upon awaking that we do realize we were in our bed sleeping, with a little exception that we'll see further on. Our view is also shared by Erwin Feinberg, who observed that the same process by which psychotic patients progress from salience attributed to irrelevant stimuli to a new, highly relevant meaning appears to occur in dreams, where a single hallucinatory image can convey an immediate, emotionally compelling meaning that is not related to the image in any obvious way. This is another important aspect which has to do with the way in which we understand psychotic thought to be built. It is a form of intuition that is long rooted in phenomenological observations on the disorder and has, in recent literature, been reinterpreted as a form of jumping to conclusions, or the tendency of a patient with psychosis to rapidly draw a conclusion from an intuitive percept, leading to the construction of a wrong belief. So, experimentally, we address the dream as a pure form of phenomenality, spontaneous production of an activated brain, detached from the environment and lacking self-reflection. This makes the dreams very, very fundamental to understand aspects of consciousness, such as the minimal self and the individual's ability to identify itself within the environment. So what are the characteristics of dreams that we are interested in? Reduced voluntary control and volition, reduced self-awareness and altered reflective thought, emotionality, which is most commonly negatively toned in dreams, and altered mnemonic processes. From an experimental point of view, we decided to focus on bizarreness, which is defined as the presence of incongruence, discontinuity, and vagueness in the dream plot, among the dream characters, in dream objects and events. A specific scale was developed at Harvard University to score dream bizarreness within the narrative transcripts of individuals' dreams. So it is very easy to understand that bizarreness scored in dreams leads to very high numbers of items. Every dream has strong incongruences and events and occurrences that cannot be traced to evidence from everyday life. But how could we compare dream narratives to narratives from patients' waking experiences? We chose to identify the production of brain activity that can be considered most close to dreaming in full wakefulness. This is commonly considered to be fantasy. When a person is asked to refer a fantastic narrative, this is possibly the condition in which they have the stronger loosening of their attachment and relationship with environmental stimuli. And they tend to produce narratives that are strongly rooted on an internal input. Recently, has been shown that individuals who lack the ability to produce fantastic imagery report fewer and qualitatively impoverished dreams compared to controls. suggesting that these two processes might be determined by similar underlying brain activity in sleep and in wakefulness. So we asked several participants, patients with schizophrenia, patients with bipolar disorder, patients with psychotic depression, and healthy controls individuals to develop fantasy stories based on a simple projective test that has been used since the 1940s in everyday psychological practice, the thematic apperception test. These were our first results, comparing a large set of patients with schizophrenia who were hospitalized during an acute psychotic break to an age and gender matched group of healthy control individuals. We were able to show a similarly high level of bizarreness in the dream narratives, but a very different level of bizarreness in the waking fantasy narratives. This shows that patients maintain a similar type of activity when they produce dreams and waking fantasies, partly supporting the view that the waking condition in a psychotic state shares some of the aspects that can be found in the dream condition. This is only true for the acutely psychotic patients because, as you see, waking narratives of healthy control individuals had a relatively lower level of bizarreness, suggesting that even when a person is stimulated to produce a fantastic narrative, the brain's ability to produce a bizarre narrative is strongly diminished compared to what occurs during dreams. We believe this to be related to the fact that frontal structures that influence logical reasoning remain highly active during wakefulness, even when we attempt to produce a fantastic narrative. This figure shows, on the right, similar results that we obtained from acutely psychotic manic patients with bipolar disorder. This is an affective condition that shares states of activation in which patients can have hallucinations and delusions and disorganized behavior as those observed in the acute states of schizophrenia. So, this observation of a high waking bizarreness during psychosis does not appear to reflect a condition related to schizophrenia itself, but rather a condition related to the psychotic mind. And this was also found to be true for patients with psychotic depression by our group. So earlier we mentioned something about the neurobiology of dreaming and what a dreaming brain might look like. This is very important to understand because if we want to have information on what is shared between dreaming and psychosis and attempt to employ dreaming as a model for psychotic experiences, we need to understand if we have enough knowledge on what the dreaming brain looks like. As we said, we believe dreams to reflect a hypoactive frontal system and a relatively hyperactive limbic system related to emotional processing. A lot of this knowledge derives from studies contrasting REM sleep with wakefulness, REM sleep with slow wave sleep, not directly from studies that can match brain activation patterns to dream narratives. This is because it's very difficult to study subjects in brain scanners for the whole night. More recently, Giulio Tononi's group in Madison, Wisconsin, developed a multiple awakening paradigm in a sleep laboratory where it is easiest to study subjects during high-density electroencephalography setups. The results of this study showed that reports of dream experience were associated with local decreases in low-frequency activity in posterior cortical regions. High-frequency activity in these regions correlated with specific dream contents. Monitoring this host zone in real time predicted whether an individual reported dreaming or the absence of dream experiences during non-REM sleep, suggesting it may constitute a core correlate of consciousness experiences in sleep. So, this study, which was done by waking subjects several times for different stages of sleeping, showed that posterior regions of the brain, which are those in which visual imagery is processed, tend to have an increase in high-frequency activity when dream consciousness occurs. As you might remember from earlier, this suggests that elements of REM sleep might be present in non-REM sleep to describe the emergence of dream consciousness. But is it possible to identify a model of brain activation that reflects differences in bizarreness across dreams and fantasies? So can we correlate specific activation patterns to a specific aspect that we have studied in wakefulness and in dreaming, but from narratives? So this is a study that we did a few years back in collaboration with Francesco Benedetti of San Raffaele Hospital in Milan. And we asked healthy individuals to record their dream narratives, fantasies, but also mundane aspects of their everyday life for a whole month. We then asked them at the end of the month to lie in a scanner and have their brain scan while they heard the narrative transcripts of their diaries, read by a neutral voice. These were all mixed up. And then we asked our analysis to contrast the brain images obtained when a dream narrative or a fantasy narrative was occurring. What we found was quite interesting. We observed 3 regions that are likely to frame a network in the right side of the brain. These regions, namely the middle temporal gyrus, superior temporal gyrus, and inferior frontal gyrus, are known to be particularly active in aspects of language that we consider to be secondary or abstract, such as the comprehension of metaphors or the disambiguation of words with different meanings. What we found was that increases of bizarreness in the narrative scripts correlated negatively with activation in these areas, suggesting that the brain tends to deactivate the areas necessary for disambiguation and comprehension of abstract meanings as we produce more bizarre narratives. So at the peak of dream bizarreness, compared to fantasy narratives that are relatively low in bizarreness in wakefulness, we have a highly deactivated network in this right side of the brain. What are the implications for this? Well, we consider this the first experimental support to Kraepelin, who postulated that language networks and frontal structures associated with abstract reasoning must be shut down during dreaming. And although we have not studied this in patients with schizophrenia with the same paradigm, we know that the same regions have been found to have a neuronal loss that might underlie the illogicity and speech disturbances observed in patients' wakefulness. How is lucid dreaming related? Well, in parallel to our study on dream bizarreness, Ursula Voss and Martin Dressler, two German colleagues, began to study lucidity in dreams to identify their cerebrofunctional correlates. Lucid dreaming, simply put, is a condition in which we acquire insight and self-awareness during the dream. Instead of being in a condition in which we firmly believe that we are waking, we become aware of the fact that we are dreaming. This is a rare occurrence, but people who frequently have lucid dreams can gain the ability to even control the dream at their own will. In line with what we have been discussing, this should somehow relate to a hyperactivation of structures that are normally shut down during dreaming. Indeed, Ursula Voss observed a reactivation in frontal structures in high frequency ranges, such as 40 Hz, that are typically found to occur when we have cognitive engagement during wakefulness in cognitive tasks. So it does seem that in the context of REM sleep, when a dream becomes lucid, we have a higher frequency activity in structures that are normally shut down. Martin Dressler also observed specific activation pattern in motor areas in a study with a combined EEG fMRI setup. When individuals who had were having lucid dreams perform motor tasks in their dreams. And this sustains a correlation between brain activity and individuals' experiences during a dream. So Martin Dressler observed that insight during dreaming, that we call lucidity, might share the same brain activation of insight in psychosis. Psychosis is typically defined by a lack of insight over the internal origin of the experience. This is the reason why patients with schizophrenia, for example, do not recognize their condition of being ill. In a similar way, as we've said, the dreamer does not recognize a condition of being dreaming, with the exception of lucid dreams. So, reviewing the literature on brain activation pattern studies in sleeping and in psychosis, Dressler suggests several regions, including the dorsolateral prefrontal cortex, frontopolar cortex, and superior and middle frontal gyri, could be the ones that underlie, could be a network that underlies insight across these two states. But what is the knowledge we have today on sleep pathology and schizophrenia? The analogies and differences between dreaming and psychosis have been rooted on the idea that we can find direct correlates between brain activity and mental activity. However, as neuroscience develops, it has become slightly more difficult to clearly frame the complexities of the brain and map them on specific aspects that are observed in pathology, especially when we speak of complex psychiatric conditions. So over the past decade, most of the research on sleeping in schizophrenia has focused on specific aspects of neural circuitry that might give us further understanding on the brain pathology in these patients. Of course, physiological indices of dreaming have been searched for since the 1960s and 70s in schizophrenia patients through EEG studies, but a direct evidence of their presence is still lacking. As Eugen Minkowski observed, the dreamer sleeps, the schizophrenia patient is awake when producing this mental state of interest. So it seems very difficult to be able to identify similar patterns across the two conditions. The literature has been focusing over the past decade on another aspect, which is the lack of sleep spindle activity or a deficit of sleep spindle activity in patients with schizophrenia. Sleep spindles are fast frequency oscillations occurring during non-REM sleep that are very interesting because they reflect the activity of a specific nucleus in the thalamus, which is called the thalamic reticular nucleus. So in the context of a research that has been struggling to map the complexity of the distributed brain dysfunction onto the pathology of schizophrenia, this is a very specific network that might give novel insights on thalamocortical network dysfunction in these patients. Early observations by Fabio Ferrarelli, an Italian colleague working at the University of Pittsburgh, on deficit of several spindle parameters in schizophrenia patients is the basis for the work we've been doing in the past few years. So we've shown this deficit to be partly present also in first-degree relatives of patients with schizophrenia, suggesting that there might be a shared genetic underpinning for this type of dysfunction of thalamocortical circuitry. More recently, we have begun to study slow wave oscillations in these patients and in their relatives, and have begun to identify the relationships that are occurring between sleep spindle activity and slow wave oscillations in non-REM sleep. But how do sleep spindles relate to dreaming? Although this has not been studied in psychosis yet, we know that dreaming is more likely to occur in the presence of fast spindles in the central and posterior cortical region, while reports of no experience preferentially occur in the presence of slow spindles in the same areas. These findings are consistent with the recent observations that subjects who report a higher number of dreams have faster spindles. So in line with our idea of a strong relationship between brain activity in dreaming and in psychosis, future research will need to address the reason why patients with schizophrenia have lower spindle counts and several spindle parameters appear to be impaired in these patients from the onset of the disease, and how this might relate to production of psychotic experience during wakefulness. These are some of my collaborators over the years. You'll see Italian, some of which working abroad. I thank all of them, of course, for this journey. And thank all of you for paying attention.
Well, thank you, Armando. That was wonderful. I'm completely fascinated, and I'm sure that there will be a host of questions. So can I open this up to the panel, the attendees? Well, there's only us on the panel. So attendees, questions? We're all still absorbing, I think. You know, maybe our spindles are a little slow.
Just for those of you unfamiliar with Zoom, there should be a little hand button in the middle of your screen at the bottom. If you click that, that'll let us know that you have a question.
Yep, I see one from Ben. Clicking on it. I'm hovering and clicking, Ronan.
Hello, can you hear me?
I think you, yes, I can hear you now. It just took a sec to come through. Hi, Ben.
Hello, thank you very much, Armando, for a really fantastic overview of really the history of dream and sleep research in relation to psychosis. It certainly makes my job a lot easier tomorrow for the team meeting. I had a question about how we understand the phenomenology of the dream experience compared to the kind of proposed neurobiology. And I guess it's this, is that my understanding of Alan Hobson's work is that that kind of bottom-up model of dreaming very much refers to the brain creating this kind of self-contained space, and corresponding to that, people's experience of dreams are often very immersive. We're in a kind of self-contained world. And in some ways, some aspects of that might map onto, say, the experience of a delusional or a bizarre overall experience of the world in psychosis. But in other respects, it doesn't necessarily match the phenomenology. So, for example, when we consider hallucinations, often they're part of or mixed into an experience of the real world. We're not necessarily immersed in them. We notice them sometimes in contrast to what else is there. And actually, something like PTSD, we might expect more kind of immersive hallucinatory experience. So if we take those kind of phenomenological continuities, but also discontinuities, what implications do you think that has for kind of dreaming as a model of psychosis more generally when we go back to Alan Hobson's model?
Well, that's a great question, and of course, as the premise was that we need to, of course, discuss the similarities, but also the differences between these two conditions. And the point you make about hallucination certainly is a very strong point, and it's something that probably differentiates these two conditions in a clear way. But I think if we go back to Alan Hobson's model and something that was mentioned in the lecture on the facilitation of the concept of organic psychosis in relationship to dreaming, and try to see hallucinatory experiences and their immersive nature on a continuum of pathology, from an organic condition to what we can call a functional condition or a psychogenic condition, something that it belongs to the psychiatric sphere of disorders. I think we have a form of continuity in terms of intensity of the immersive experience. A patient with a delirium who has an organic psychosis, so this is not schizophrenia, but it would be someone with a metabolic issue, a brain disorder, or someone with alcohol withdrawal syndrome, is a patient who can enact his behavior on the basis of the hallucinations in a very clear and evident way. And also the multimodality of the experience is more dreamlike and more intensive. So the more we shift towards an organic pathology or something that is known to be organic, because this is, of course, a purely philosophical distinction based on the point at which we are at the moment in our ability to discriminate the brain pathology underlying these conditions. But if we have a strongly neurologically based pathology, we have a very immersive and dreamlike hallucinatory experience for patients. And this can reach an intensity and multimodality, which is not reached by a patient with schizophrenia. Another example besides delirium could be that of a hypnagogic hallucination or another hypnagogic experience. So there are experiences that occur on the edge of sleep, and there are experiences in which there is a dissociation between wakefulness and dreaming. So patient can be in a sleeping state from a physical point of view, but can be mentally active and awake. And in this condition, you can have elements of dreams recur into the patient's waking cognition. This is another example of an organically based disorder and disturbance, and it is indeed more immersive in hallucinatory terms. The more we shift along this continuum towards a pathology of which we fail to understand the brain basis clearly, the more we have, I would say, a subtler hallucinatory experience. My understanding of this is that possibly in the lecture I was somewhat sharp in saying that psychotic patients fail to update their internal world on the basis of the external feedback. But of course, this is not black and white. This is not so clear-cut and sharp. The patient is awake and he is in interaction with the environment and with the external world. Part of the feedback probably helps to regulate the immersive nature and sort of draws him out of the immersive hallucinatory experience. I think that a proof of this is historical. We do, and I think that the historical proof is, that's why it's important when I talk about this to start off with the observations from Minkowski, from Jung, and also from Sigmund Freud, of course. At the time, patients did not take medication, okay? So patients with schizophrenia, this was before the 60s and 70s, had no form of adequate treatment for their condition. If you look at the descriptions of the patient's behavior, it was very much more hallucinatory driven than we expected to find today in a patient with a treated condition. It's very difficult today to find patients who have a long history of a severe disorder such as schizophrenia who have not had access to treatment. When you do have patients like that in your observation, it is possible to see a very more immersive nature of the hallucinatory experience. I believe that the medication, this is of course very important, and I'm very happy that we do have medications for these conditions, is a great aid towards pushing back along this continuum towards a more, a less immersive experience for the patients. But I believe that researchers, philosophers, and psychiatrists and neurologists who observed schizophrenia patients 100 years ago before medication saw something that was much more similar to a full immersive experience, such as an organic psychosis. I'm not sure if I answered your question.
I think, can you still hear me?
Yes, yeah. We can hear you.
That's a very comprehensive and well thought through answer, Armando. And thank you for it. I think it does clarify a few things. I guess just one brief point to make is that obviously for some people would argue that something like schizophrenia should be considered more organic than anything towards the other end of the continuum. It's almost it's a matter of debate where you place that label on our current state of knowledge. But the way you described it is really helpful. So thank you.
Rob, I think you put your hand up next. Is that working?
Can you hear me?
Yes, yes, you've got through. Carry on.
Okay, thanks for a fascinating talk. I have many questions, but I'll restrict it to one at this time, and I'm not even sure if it's a coherent question, so forgive me if it's not. But we've had some discussion, and I really wrestle with the question of the relationship between the dreamer's experience and the dreamer's reported. And as you were speaking, I was just wondering whether, you know, there's anything to be said about the likelihood that that relationship is likely to be the same for your people in your schizophrenia experimental groups and your controls. And I'm not even sure if there is in principle any way of getting at that, but can you say anything about what the study of dreaming in schizophrenia might reveal or tell us about the relationship between the dream experience and the dream as reported?
Well, yes, I understand that. I think this is a very good point. This struggle you refer to is, of course, one of the major reasons why we have such a difficulty in mapping mental activity onto brain function. And this is certainly, I mean, an issue in the whole of psychiatry research. And this possibly is also one of the reasons why it is so difficult to relate the underlying brain pathology that can be observed at a group level to what are the individual experiences of the patients. A lot of theorizing on the mental activity of patients with schizophrenia is actually based on prototypical patients. Wolfgang Blankenberg, who was a phenomenologist, wrote a very fascinating book on the loss of natural evidence as the experience of a loss of basic self in patients with schizophrenia. And he was an author who was very, very much interested in the idea that we need to have the subjective experience of the patient completely explained. And we need the patient, we need to enter in a full contact with what the subjectivity of the patient is to truly understand his pathology and truly characterize it also as external observers. And so his take on this was that very few patients are able to clearly describe and explain their subjective experience across stages of their disorder. And this can be in the prodrome, this can be before they develop symptoms, it can be during the development of delusions, and it can be in the description of their hallucinatory experiences. Karl Jaspers, another philosopher, cut this far shorter in saying that there is something incomprehensible in the experience of a patient with schizophrenia. And this is quite a common view on the disorder. But what Blankenberg teaches in this is that if we have the ability to understand the subjective experience of those few patients who can describe it in a very open and narrative way, then we can attempt to bridge their experience to that of several other patients who might simply be more impaired, less comfortable in the interrelationship with the clinician, or more impaired in terms of verbal production, for example, and the ability to communicate. So a lot of what we say really is based on a theory of what the subjective experience is of a schizophrenia patient, drawn by a few prototypical patients who have been able to describe it very well. When we look at something like a narrative, and of course, the research I showed is on dream narratives or fantasy narratives, but there's a lot of research in schizophrenia on patients' narratives, and this can be also on their delusional themes and all sorts of things. Then, of course, we are bridging something in a very biased way. This is not the patient's subjective experience, exactly in a way that the dream narrative is not the dreamer's experience. My idea is that if we contrast two things that have detached from the experience at a similar level, then we can draw some inference. But of course, the fully immersive experience that it is the subjectivity of a subject with psychosis or the subjectivity of a dreamer is far more complex to grasp, and that is possibly the reason why something like bizarreness is only a small aspect to measure from a larger experience.
That's lovely, Armando. I see we've got one more question. We are running out of time a little bit, so I'm going to open this up to Sophia, hopefully. And another one that's just come through.
I think there were some written questions also somewhere.
I'm trying.
Yes, I'm Sophia. Can you hear me? Yep.
Yes, yes, we've got you, Sophia. Don't worry.
Okay. Hopefully this is a quick question anyway. I was really interested to see what you said about some similar dream qualities of schizophrenics and their near relatives. So my mum's brother is schizophrenic, and I was wondering, is there something specific then that she could pinpoint about her dreams, which would differ, for example, from mine or from someone who wasn't related to schizophrenic? I wondered in practice, what would she notice?
I think you probably, I think the aspects of dream narratives and dream experiences have not been studied in first degree relatives, or maybe there's only one study, but not that I can remember at this point. But I'm sure the one you heard during the talk was a study on electroencephalography of sleep, in which we identified the sleep spindle deficit in first degree relatives of patients. I would say that this topic is quite broad. There is a vast literature on what we call endophenotypes, which are some, I would call them biological markers that can be observed in patients and are also present in their first degree relatives, usually to a lesser extent. Typically in the endophenotype literature, these markers are in between someone who does not have a relative with schizophrenia and who has not the disorder, and a patient with the disorder. The presence of the marker usually suggests that there is a genetic liability towards that form of network dysfunction, but that the network dysfunction itself only becomes evident in its dysfunctionality when the pathology occurs. So what I mean is that in a first degree relative who does not have a disorder such as schizophrenia, you do not expect that marker to be related to some form of disability of any sort. So the sleep of the family relative, we had mothers, fathers, sisters, brothers who very kindly helped us on this study. Their sleep is not disturbed in clinical terms. They don't have insomnia, they don't have sleep fragmentation, their cycles in sleep are adequate and physiological, but only at a very close study with a high density electroencephalography of a specific marker, which is this fast frequency oscillation, could we identify a slight impairment. So it's not really something that we can consider pathological in relatives, and it's not really something that is able to determine the disorder itself, but it's something that is very important for research on the marker.
Okay, can we manage one more quick question, please, Armando? Is that all right, Megan? Just, I know you've been waiting for a little while there. That should have brought you in.
Hello.
We've got you.
Hiya. So I have a question, not strictly about schizophrenia, but some related disorders. I hope it's quick. I was just wondering, there was something you mentioned about psychotic patients usually having a lack of orientation and being more inclined to audio hallucinations and abnormal behavior, for example. And I was wondering I've read before about some patients with borderline personality disorder or, for example, complex PTSD, where their paranoia can cause auditory hallucinations, and like in personal experience with people I've met, very bizarre dreaming as well. And I was wondering if you could perhaps give me an indication of where on this scale of organic psychosis to more extreme psychosis you would classify, for example, these more extreme cases of complex PTSD and BDP where they're not, where, for example, the patient could be having audio hallucinations, but could be completely aware of that. And so there's those conflicting symptoms that are perhaps not present in schizophrenic patients.
That's an excellent question. Well, first of all, my first answer would be I have no idea.
That's no problem. I feel like it might be
not
your area of research.
No, not to mean that I don't take the point or enjoy this question. It's that really we don't know. I can tell you my thoughts on this, but I wouldn't consider it strongly based on evidence, which is.
I mean, I'd still like to hear your thoughts.
It's not that strong in this area. You know, psychiatrists have moved towards neuroscience over time, and this has happened in the past 20, 30 years. Before, we used some terms that tended to split things more easily. So the type of, because we only used clinical terms, psychopathological terms, and we didn't need to refer to the hypotheses of underlying brain activity. Now it's become far more complex. So I would say that in clinical terms, they're in a completely different domain. There are types of patients who would have typically, their hallucinatory experiences would have been described as dissociative in the past. So they would have been described as experiences determined by a form of conscious dissociation. So, a dissociation of consciousness. So not quite a psychotic experience. And the dissociation of consciousness as a concept would have been the explanation for the preserved insight. So it's as if the person was experiencing something that is in a form of splitting, and inside they have the knowledge that this is not possible, not true, not coming from their own mind. Today we don't use this term anymore, but we still consider this type of patients in another field with respect to schizophrenia and these type of psychoses that are usually considered on a continuum with the organic forms of psychosis. If you only take the hallucinatory experience, of course, they stand on a continuum of insight. So that is the type of continuum with which you could compare them with the experiences of a patient with schizophrenia. At one end, you have a loss of the ability to describe the internal origin of the experience, whereas on the other side, you have a preserved ability and often a full ability to describe it. The qualitative nature of the experience is theoretically identical. Because if the patient, as I was saying before, we can only refer to what a very, very explanatory patient can tell us on their subjectivity. And if you ask a patient to describe what they're experiencing, they will probably tell you that they are hearing a voice which is saying certain things, and the voice has a tone and a quality. So this is not different in the two conditions. What differs strongly is that a patient with schizophrenia will not recognize the internal origin of the experience. Of course, this is in the natural condition. There are therapies, there are treatments, there are medications, psychological interventions that can aid the patient towards acquiring some form of insight on the experience. But in a natural condition, a patient with a schizophrenic hallucination will not have insight on the internal origin, whereas the patients with a borderline personality disorder or a complex PTSD will generally have the insight. This is, of course, all in general terms. This is the reason why we call them pseudo-hallucinations. I'm not sure if Ben wants to add something on this. He's such an expert on hallucinations.
He sent a note saying he had to go, in fact.
Okay.
He said, thank you very much indeed. I'm sure he can add it at some other time. We have gone over time a little bit, so I'm not going to ask any other questions. But for somebody who said, I don't know about that last question, you actually came up with a lot of thoughts about it. And this is the stuff I love about our IAS fellows, is that you just kind of ask them a question and this wonderful fountain of information emerges based on their depth of knowledge. And so it's all very wonderful. So thank you so much, Armando, for giving us a very lovely first IAS public lecture of the year. And we look forward to seeing you at our formal Fellows Welcome tomorrow. I'm sure that everyone who has been listening will have more questions for you at other stages. I've been bottling several myself, but we'll save those for another day. So many thanks. Thanks everybody for coming along and asking such good questions. And we look forward to this conversation evolving over the year. So take care, everybody. Bye-bye.